finance department, helping with the capital budgeting project, and also on a physician quality scorecard. The past 10 weeks, that's been most of my work. And then besides that, I've worked on this presentation on collaborative care, the collaborative care model. And I'm going to tie that in today with Intern Healthcare's PCBH program and get some recommendations for improvement. So I'll go ahead and get started here. So again, kind of reiterating what I was saying earlier about the objectives. So first, I can define the collaborative care model. So what that is, kind of the evidence behind that, some of the background behind that. Discuss Intern Healthcare's integration of behavioral health into primary care. Then furthermore, discuss some of the benefits and challenges of the PCBH program as well. And also provide some recommendations for improvement. So for starters, the collaborative care model will be defined as the integration of behavioral health care providers and primary health care providers working together within a primary care setting to deliver care to patients. It was developed at the Advancing Integrated Mental Health Solutions Center, AIMS, at the University of Washington. They've kind of, for the past about 15 years now, since '04, they've moved into the development, implementation, and then finding more evidence behind why this model of care works and why it should be used in other health systems as well. And so here's some of the pillars within collaborative care. So the first one, and these are the 5 main pillars that make up what it is. The first pillar is patient-centered team care. So what that means is that, kind of reiterating the point earlier about how primary health care providers and behavioral health care providers work together within a primary care setting to deliver clinical outcomes for patients and also provide patient satisfaction, so just treating the patient. The second pillar would be population-based care, which revolves around so patient populations being tracked within a registry and their clinical outcomes, their satisfaction, and where they end up in terms of health-wise is also tracked within these registries. And then the third point would be measurement-based treatment. So what that means is that, so for example, it's kind of at least a newer idea to per se measure a patient's blood pressure, right, for behavioral health, right? So in the past, it's very routine to get your blood pressure measured within a primary care setting, right? But with the collaborative care model, now we're talking about measuring a patient's blood pressure within a behavioral health setting, right, to kind of show the correlation there that behavioral health matters. So if a patient has generalized anxiety, their blood pressure would be measured beforehand and then down the road afterward to show that there are some outcomes either improving or maybe there needs to be more work. So things like that, that's been utilized within the pillars of collaborative care. Then the fourth point there is evidence-based care. So what that means is that the latest psychotherapies, the best psychotherapies should be used on patients. Again, that kind of plays to the point where patients aren't receiving outdated forms of psychotherapy, they're receiving what's up to date. And then the fifth pillar would be accountable care. So that means that the providers are held to account or reimbursed based upon the clinical outcomes of patients or their satisfaction, right? So if a patient's not improving, there could be something done about that on the provider end because that means it's something, obviously has gone wrong there. So those are the 5 pillars of the collaborative care model. And all of those are very important factors in considering, what this model is, and I'll get into a little bit more of the evidence behind this as well. So the first piece of evidence I'll point to is something called the impact trial. And this is really pointed to as one of the main foundations of the collaborative care model being built. So what it was a team of researchers led by a Dr. They tracked 1,801 depressed older adults. And so what they did was they gave half of the patients the impact model of care, which would later go on to be known as the collaborative care model. Then the other half of patients, they gave the usual depressive treatment, right? So maybe something a little more outdated that we think of today. And so what happened was, about 12 months into the study, patients were asked, how are you doing in terms of your depression? Well, the patients who received the impact or collaborative care model reported a 50% decrease in their depressive symptoms, whereas patients who received the regular, usual depressive treatment, they reported only a 19% decrease. So, as you can see, there's quite a discrepancy between, collaborative care model, regular treatment. Seems like collaborative care or impact in this case is kind of winning out. And then additionally, the second point there is that patients from the impact trial were actually tracked a little bit longer. So the Journal of Psychosomatic Medicine, they actually found within a paper that patients who received the impact model of care were less likely to receive a serious cardiovascular event or a fatal cardiovascular event, which is huge, right? And so again, that kind of points to the fact that collaborative care is a model of care that has some evidence behind it. And then additionally, very recently, the Centers for Medicare and Medicaid Services, or CMS, they actually moved to provide coverage for the collaborative care model in 2017, roughly 2018. So, pretty recently, they looked into this model of care and said, well, this is a very important thing, and it's something we see long-term value in within healthcare. And so we kind of discussed what collaborative care is, the code behind that, the evidence behind that. I have to look into Hennepin Healthcare's primary care behavioral health program, which is PCBH, is what's shortened there. And PCBH follows a very similar model for the collaborative care approach. And so the first purpose of PCBH, one would be to fill the gap in between primary care and specialty psychiatry / adult psychiatry. PCBH is kind of that middle ground for patients who have the mild to moderate conditions. It's not for the more severe cases you'd see within specialty psychiatry, for example. And then also, it's meant to reduce the number of referrals to specialty psychiatry because traditionally, providers have been used to referring patients who have those severe cases to specialty psychiatry rather than having kind of that middle ground by which to treat patients. And these are some more further purposes. Again, it's meant to also increase the volume of patients seen. So overall, more patients are being seen with PCBH. And also it provides some education to primary care providers as well. So I'll get into this a little bit more down the road within my presentation, but for example, there's various lectures for primary care providers about depression or anxiety, things like that that can be done to kind of help further get some training behind that. And then I have to say this because this is very important. It's not a replacement for psychiatry. PCBH is not a replacement for psychiatry, right? So patients who go to PCBH, this is not meant to get rid of psychiatry. It's just a middle point. It acts as a screener essentially for patients with mild and moderate conditions. So if they're not in specialty psychiatry, which is in a lot of ways it wouldn't be the right level of care for them. And then again, it's not long-term medication management. You see that again more in the high-level specialty psychiatry. And so this is a graphic kind of detailing what I was talking about. So you see at the bottom, here's primary care, right? It says screening for mental health conditions by primary care provider. So it's going to be mostly screenings. It's not going to be in-depth consultation. That would get more at the middle point of care for PCBH, but I'll kind of skip up here for a minute to specialty psychiatry, where you'll have inpatient, you'll have the kind of long-term psychotherapy. Typically, from my time here at Hennepin Healthcare, what I've gathered is that in specialty psychiatry, it's usually about 10 visits or more, right? Or it's inpatient, so you're here for quite some time. Or if you're in PCBH, the middle point of care, it's about 6 visits or less. If you need more PCBH, you can come right back and have some type of psychiatry consultation, things like that. And again, this is one of the most important points. This is about the right level of care. So mild to moderate conditions, generalized anxiety disorder at the mild level, moderate bipolar disorder. You're not necessarily going to want that up here, right? So it acts as a screener, it's very important. So PCBH fills that kind of gap in care, so to speak. And then here are the goals of PCBH. I've reiterated these points, but I'll kind of go over it once again just to drive it home for you all. So again, the right level and type of mental health services. Providers actually being satisfied with the health services that they're giving to their patients. And then additionally, it says all patients, but really more patients have access to some form of integrated care. So again, PCBH fills that slot pretty well. So here's some clinics with PCBH. I could read these, Brooklyn Park, Golden Valley. There's just a better picture of what one looks like. So here's the St. Anthony's Village Clinic, a little hard to read. Down here is the Richfield Clinic. And some of the newer ones, like the North Loop Clinic down here, again, you see PCBH does seem to be kind of expanding and catching a lot of fire, so to speak. And so this is what I said I was going to touch on a little bit later on. About the patient and provider education. So the first point there is something called care packages. So what that is it's a manual or handbook for patients who have ADHD or depression so that they don't have to necessarily run right back to a physician, right? They have some type of informational, slot to analyze their conditions and have some background there as well. And these are italicized for a reason. So these are the titles of lectures given to providers. So the first lecture here says Management of Depression and Primary Care. Again, these are more for primary care providers, right? So lectures in depression, lectures in anxiety, PTSD. Bottom one there is controlled substance prescribing and substance misuse in primary care. So again, substance use disorder, another major point, big factor there that we also have to look into as well. And before I get into this is feedback that patients have given in the past based upon surveys, right? So the first one reads, I'm very happy with the doctor and everything she does to help us. Thank you for having this type of help for other people who need it. I would recommend this provider. So obviously very positive patient feedback, right, very good. Second one reads, again, it's very positive. These sessions have improved my feelings of self-worth. They also help with the spiral of depression, making a better and happier me. So, things like that we're looking for, from surveys that, kind of demonstrate that patients are satisfied with the care that they're getting as well. It's very important. And so I've kind of discussed collaborative care, PCBH. Now we have to look into some of the challenges from a health system perspective. I will look specifically at Hennepin Healthcare, but the first point is actually a nationwide deal. It reads psychiatry provider. So there's a nationwide shortage of psychiatrists, and it's not just Hennepin, but Hennepin does have a shortage of psychiatrists as well. And a lot of that has to do with cost and availability. For example, having a psychiatrist is usually more expensive than having a psychologist, right? Because psychiatrists are medically trained, but patients do tend to want more from a psychiatrist. And then measuring health outcomes of patients. So since the rollout of PCBH in 2013, measuring the health outcomes of patients in terms of this patient has diabetes, asthma, and they also have anxiety or depression, it's been difficult to link that directly to PCBH in terms of them getting any better, right? So we can show that they've been to PCBH, or maybe there's less ED visits, for example, but in terms of directly linking it back to, if a patient is better anyway, directly linking that back to, well, it's a result of PCBH, that's been very difficult to prove. And so there needs to be more data behind that, is the point. And then also it's a change in culture. Again, PCBH is relatively new, so it operates on or at least traditionally, it's been a very strong referral-based system. So, patient with behavioral health condition might be referred to a different level, right? That it's about keeping them within PCBH for that mild to moderate condition and right level of care as well. And so this is a very important point. Everyone in this room, if you're a health professional, right, you care about, or you should care about the stigma in mental health. So what I mean by that is, you could talk to someone who has a mental illness, or patients, or whoever, and a lot of times they have a lot of hesitation and anxiety about coming forward with their illness. Oftentimes coworkers, friends, sadly sometimes family, they'll look down upon them, and I don't want to talk about that. Okay, that's difficult for them. And so someone who struggles with mental illness, it's about education around that and making sure that we all, within the future, know about these sort of things, and we care enough to actually address this. I mean, I'm sure at least someone in this room knows someone with mental illness. So, we all know that it's not some new phenomenon, right? It's been around, and something we have to continue to address moving forward. And so, touched on stigma. This actually relates very closely to the stigma in mental illness. Culture and health, right? So the first example I'll give of that is managing chronic illness. There's variations within managing chronic illness dependent upon culture. So for example, I know within Somali culture, if you come forward and say, well, I have anxiety or I have depression, you'll be shunned or excluded. It's not something that's very much talked about. It's just one of those things where, you may want to come forward, but you won't. You probably won't, because you fear some repercussion based upon that. And then also just physician training. So again, just having physicians be aware of these cultural variations in terms of, again, I point to Somali culture. It's about having physicians who understand these variations and are able to address that. It's very important. And then also have their mental capacity. So I'll give the example of a physician says, you understand you have, or you need treatment for X, Y, Z, and the patient kind of nods their head, yeah. Right, it doesn't mean they understand what's going on. So that ability to consent to or refuse care, physicians and health professionals need to be not just trained on it, but be aware of that at least. And so I had about, I spent about 4 hours with a Dr. Zaris, who's a psychiatrist within PCBH, within internal medicine. And 2 of those hours, he kind of showed me the operational aspect. Kind of showed me, how he, tracks patients, things like that. The other 2 hours he spent with me, actually shadowed. I went behind the curtain and I got to see some patients as well. So I'll start with this. There were patients who had, again, diabetes, asthma, depression, bipolar disorder, right? Again, mild to moderate forms of that. I shot about 3 patients in total, and one of my first observations was that the meetings were really quick, and I don't mean that in a negative sense, but I mean that about 30 minutes a patient, which does seem to be about the marker that we probably want when looking at time spent with patients. So what that consisted of was some psychiatry in terms of, Dr. Zeres would ask them about kind of their life story, traumatic events that may have happened, and then prescribe them something as well. Some patients had like bad knees, things like that. So it was pretty quick, about 30 minutes. And then also, based upon what patients said, right, based upon what they told Dr. Zeres anyway, they seemed to thank him a lot, like, oh, thank you for sitting on top with me, I really appreciated that, I really, thanks for, I don't really have anyone else to talk to this about. They really seemed to appreciate their time with Dr. Zeres. So I said it was quality service based upon that. And then additionally, another observation was provider availability. So what I mean by provider availability is Dr. Zeres was pretty busy. There were some kind of longer wait times, so to speak. Again, he was one of the only psychiatrists who sought after. And so kind of having that availability for patients would be, a great thing as well. And then additionally, access. So there were some patients that didn't show up for whatever reason. I kind of talked to Dr. Zeres about perhaps what that could be. And, he told me sometimes it's things like transportation. Sometimes we just don't know. There's a lot of reasons, but, things like that are also something to look at and take into account. And so here's the part where I give some recommendations. So the first recommendation I have is care coordination codes. Those are essentially just billing codes. So what I gathered was that for whatever reason, it's been difficult to track these billing codes. So for example, a nurse that works on the PCBH team, he can only bill for 20 minutes of time interfacing with patients via maybe on the phone, right? So let's say he works 5 minutes one day, or he interfaces with the patient 5 minutes one day, then 10 minutes the next, then it's 10 again. He goes over the 20-minute limit. Apparently, it's very difficult for that nurse to track that time spent. So, and it has something to do with the Epic database. For some reason, it's been very difficult to track those billing codes within Epic. So maybe, finding some software swap, or perhaps just finding out what we could do to better fix that within Epic would be something that we look into.
And if there's time for questions, that was one of the first areas that got my attention and focus when you started off talking about the care coordination model and cutting across the 3 pyramids. And I got thinking about the care coordination clinic with Dr. Paul Johnson.
CCC.
If there's, they're kind of doing this work, but in a different space, with HIV and social services and
High demand.
high demand. And
I think that actually started under John Bluford.
Okay.
So
that being said, we have another service line that's kind of doing this work. We have cross billing options.
Yep.
So if there's anything, posing the question, if there's anything that can be learned from that.
I think there could.
Here.
That's a really good point. I mean, I think the CCC, although the question would be how good is the CCC doing the coordination of codes, but we spent a lot of time on that, on improving the billing of that, because it's complex. So that might be some way we could help, because we might be able to link them. It's a good point, Walt.
I'm almost finished up here, so I'll have a portion for questions in just a bit. So the second recommendation would be expansion of PCBH and specialty clinics, where, again, what I gathered based upon speaking to leaders within behavioral health, is that patients within specialty clinics, so orthopedics, cancer center, senior care clinic, they want some form of PCBH or some, at the very least, some behavioral health provider there to, give them some form of psychiatry or therapy, things like that. So, maybe meeting patients on those needs would be a great move going forward. And then additionally, just more care packaging. So maybe more informational aspects or more manuals for patients, let's say, who have anxiety or bipolar disorder. We know that we have care packages for ADHD and depression, but perhaps expanding that also so that patients who have other conditions as well have some sort of manual or something to look at, so they don't have to only chase down a physician. And so, in conclusion, or at least the takeaways I hope you all have in this presentation, or something to think about, would just be the importance of the collaborative care model. PCBH does seem to be hitting a lot of the pillars, but again, measuring the health outcomes aspect is something we really look into, right? That measurement-based treatment aspect. And then additionally, just continuing to prove the worth of PCBH. So showing that, and it goes back to health outcomes, that patients who have, this physical condition, this mental health condition, that based upon PCBH, they're actually improving. It's not enough just to say, well, they came here, I hope they're doing well, they said they were happy. Some sort of quantitative data behind that down the line would be great. And then additionally, this is a general point, but it is very important in whatever clinic or department, wherever we go. This is a crucial point. Just culture and health in general. Being aware of diverse patient populations, understanding their needs, understanding our needs, understanding and kind of knowing where to go with that, being trained in that, having some form of education behind that is also a very crucial point I'd like to make, and hope you all walk away here with some, at least some insight into that and understanding that, it's something that is very important within healthcare. And so, holy applause. This time I'd like to thank everyone who's worked with me, Heaven Healthcare, Sammy Minch, Dr. Zaris, who's not here, great guy. Joellen Koslowski, I know she's on vacation. Eric, Amy Harris Overby in here. Aaron, thank you. Charlie, Vera, Lisa.